my pleasure to introduce you to today's speakers. We have two, Dr. Holly Russell and Ms. Michelle Lawrence. So really quickly, a little bit of a bio on these ladies. Dr. Russell is an assistant professor of family medicine at the University of Rochester Medical Center. Dr. Russell is a board certified in addiction medicine and is the founder and director of the Addiction Medicine Program at Highland Family Medicine. For the last 3 years, she has been working on a project looking at how to expand access to treatment for opioid use disorder within primary care settings, including the use of telemedicine technology. Our other presenter is Ms. Michelle Lawrence. She is the co-principal investigator for the University of Rochester's Recovery Center of Excellence and an assistant professor of psychiatry and community and preventative medicine. She has worked closely with rural Appalachian communities for over 18 years, creating financially viable hospitals, primary care, behavioral health programs that partner with each other to improve the health of these communities and all of their residents. So as a reminder, please type any questions that you have during the presentation in the Q&A box. And now, Dr. Russell and Ms. Lawrence, the mic is yours. Can you get it?
Best laid plans, right?
There we go. You got it? No worries.
My mouse just stopped cooperating with me for a second.
You're good.
All right. So thank you so much for welcoming us. I do have control over the slide. There we go. Okay. So Michelle and I would like to share that we have no financial relationships to disclose. And briefly to go over our objectives, we'll start with an overview around opioid use disorder as a chronic disease. We'll provide information for you on how to establish a bridge medication for opioid use disorder program in your community, which we hope to show evidence can improve access to pharmacotherapy. And then we will discuss transitions that may occur over the years of treatment and how to support patients through these transitions. To start off, I'd like to share a word about the terminology that we use. So many of you might be familiar with the terms medication-assisted therapy, which is often abbreviated as MAT. You'll hear that commonly in many talks about that. As we understand more about substance use disorders as a chronic disease, we're really trying to move towards using the term medications for opioid use disorder. It's felt that medication-assisted treatment, or MAT, can perpetuate the stigma of substance use disorder as different than other chronic diseases. We would never describe the use of metformin as medication-assisted treatment for diabetes, or say MAT when we're talking about diuretics for blood pressure management. And so we're really trying to get away from the acronym MAT and instead use medications for opioid use disorder, which is abbreviated MOUD, as you can see here, or simply call it pharmacotherapy. There are 3 types of medicines that are approved by the FDA to treat opioid use disorder. All 3 work primarily on the mu receptors, the opioid receptors in the brain. Methadone, which is a full opioid agonist, has been approved since the 1970s for use. However, it can only be prescribed for opioid use disorder in specially regulated opioid treatment programs, often referred to as OTPs. Buprenorphine, which historically has been used parenterally or IV as a pain medication, is a partial agonist on the opioid receptors. And because it's only a partial agonist, there is a ceiling to the opioid effects, and it is nearly impossible to overdose on. In 2000, a special law that we will discuss more allowed buprenorphine, commonly prescribed in combination with naloxone, to be prescribed as treatment for opioid use disorder in settings outside of traditional opioid treatment programs. This law was also recently updated just a few months ago, and so we'll also talk to you about the recent changes in the legal regulation of buprenorphine. Thirdly, there's treatment with naltrexone, which is a full antagonist, so it blocks any activity on the opioid receptors. This is available in both an oral medication, which was approved in the 1980s as a treatment for opioid use disorder, but it actually became more popular in the 1990s as a treatment for alcohol use disorder. And it's available now in a long-acting depot injection, which the brand name is Vivitrol. We always like to remember that determination of which medication type to use is based on the individual patient's need, as well as community access to treatment options. Psychosocial therapy is also very important. However, the evidence around the psychosocial therapy is less robust, and all newer guidelines enforce that medication or pharmacotherapy should not be withheld if behavioral treatments are not easily available, or if patients are not agreeable to doing the therapy. In today's discussion of telemedicine, we're going to primarily be talking about buprenorphine or brand names Suboxone or Zubsolv as the focus. All right. So the problem is that I'm trying to use my mouse on two screens here. All right. So medication for opioid use disorder is an evidence-based practice that significantly decreases mortality. And we have decades of evidence for using this across different continents and many different populations. The treatment is generally underutilized, but it is urgently needed, and all the more critical now that we're seeing this current wave of overdose from intentional and unintentional synthetic opioid use. I also want to highlight that while treatment is not available in general as much as we need it, there are also huge disparities in access with certain populations and in certain demographic areas, certainly in rural populations. These treatments can be used in various settings, including emergency use departments, substance use disorder treatment centers, as well as my focus, which is primary care. So once again, we're going to really try to think about opioid use disorder as a chronic disease. So if you think about any other chronic disease, if you think about diabetes or hypertension, all of these chronic diseases are influenced by a patient's behavior. Screening for these chronic diseases is promoted and should increase access to treatment. There's no cure, but there are effective treatments with predictable outcomes. And when we discontinue the treatment, we predict that there would be an adverse outcome. Chronic diseases require continued oversight and empathy by the physician to ensure adherence to treatment. However, oftentimes when we think about substance use disorder, we have very different expectations for the patient and the treatment. We think that there is moral failure or bad behavior is what causes the disease. We really don't do a great job with screening. We think that patients should have self-restraint rather than a treatment medication. And we think that when we stop the medicine, that there should not be an effect. And in fact, oftentimes we stop the medicine when the patient is not doing well, which is the opposite of what we would do with almost any other chronic disease. And in general, PCPs are not involved. The principles of treatment of all chronic diseases involve changing deeply embedded behaviors as one part of treatment. Relapse is also quite common, and if you look at rates of relapse across all chronic diseases, they're very similar to rates of relapse with substance use disorder. And relapse with all chronic disease indicates that we should think about alternative methods of treatment, not that we should discharge patients from treatment. So as I mentioned earlier, the laws recently changed so that there is a different legal regulation around who can prescribe buprenorphine. Back in 2000, when we first were allowed to use buprenorphine in settings outside of opioid treatment programs, as part of the rule, they created this training program that people had to attend, either a fellowship, a specialty training in addiction medicine, or completion of an 8-hour course. And when the law was originally written back in 2000, only physicians could prescribe buprenorphine. And this was then addended so that in 2016 with this Addiction and Recovery Act, so that other practitioners, including advanced practice practitioners, could complete 24 hours to be waivered. So now the recent regulatory changes, so interestingly, I think this is a workaround. So they didn't have to actually take the law away, but they sort of altered the law. So you still do have to register for a waiver, but you do not have to attend a specific 8-hour training or any training. So you still do have to go online and get the special DEAX waiver, but when you go online, you don't have to check a box that says you did this specialty training. And you also do not have to check a box saying that you can refer patients for counseling and ancillary services. This was also thought to be a barrier because people interpreted this to mean they must refer patients as opposed to having the capacity to refer patients.
So there's several issues when we look at implementing this strategy in rural communities, particularly with primary care. And several of the challenges are listed here. And part of the reason that we developed this bridge program really was to allow the space and the time for communities to be able to address these challenges. So one of the purposes of the bridge is to allow the time for people to be able to address everything going on here. So some of the things are the negative experiences and associations that primary care providers may have with working with patients with substance use disorder previously, or interfacing with substance use disorder patients in their communities. On our website, which we'll give you the contact information for later, we also have some information about stigma, and we'll begin hosting stigma workshops across the United States later this year. And it's really, those are aimed at really addressing some of these negative experiences. There's a lot of concerns about the diversion or misuse of medication, which Dr. Russell addressed already in terms of buprenorphine not necessarily being something that it's, you know, hard to overdose or abuse in that particular way. In many communities, there's a focus on abstinence. We saw that a lot in New York State, and we've really shifted over the last 5 years to focus more on harm reduction. Many primary care practices have very limited staff size and preparedness. So there are also some programs that we talk about in further detail around supporting primary care with disease management, care management, much like you would for other chronic diseases. There can often be limited office space, and that impacts patient privacy and workflow. So again, the bridge can be very helpful here in that it allows patients to really begin to engage in treatment initially with your local substance use disorder treatment providers, and then come back to your office when they are in recovery and you know, fitting into your workflow, just like all of the rest of your patients with chronic disease would. And that also makes it easier in terms of managing the patient population. So, you know, the program doesn't look to primary care providers to actually begin that treatment, which can take a lot of time initially. I talked a little bit about mental health and substance use treatment organizations. You do want to make sure when you're doing this that there is appropriate access. And one of the things that we found is that the Bridge program can actually help these organizations by helping them to be able to transition patients who are well on their way to recovery, where they may not have the opportunity to transition back to their primary care provider yet. The Bridge can be a temporary holding place where these patients can continue to maintain their recovery, and these other organizations can continue to get patients into treatment. Dr. Russell addressed the X-waiver training. And there are often questions about the financial impact on the practice. And really, as we move more and more into gain sharing contracts, and even just looking at efficacy of disease treatment overall, by treating mental health and substance use disorder, we are actually able to see better efficacy in overall medical care that is provided to our patients in other areas. Next slide. The Bridge program and medication for opioid use disorder has an impact on the community as well. So there is a much greater risk of mortality when patients are not treated. And this can impact the community and impact families and impact the workforce. In addition, patients who are trying to access this treatment, if it is not available in the area, they may be driving hours away, and this often impacts folks that are trying to assist them as well, whether that's family or friends or others, and it impacts their ability to hold down a job. Without MOUD, patients who potentially go through some treatment in a mental health or substance use organization can come out of that and not be able to access treatment through their recovery, have a lower tolerance for, if they begin using again, and end up with a higher risk of mortality. And then I talked a little bit about stigma already, and so we want to try to reduce stigma. Next slide, please. So again, what is the Bridge program? So this is really designed to be a short-term, just 2 to 3 year program that allows patients to access ongoing MOUD treatment after they've accessed their acute treatment. And we generally can do this by telemedicine. So Dr. Russell provides this by telemedicine now into several of our rural communities. And during that time, the community can work to increase MOUD access through primary care practices for patients that are already well on their way into recovery, and to increase the front door really on treatment organizations to allow more patients to get into recovery. Next slide. So we're going to talk a little bit about how we build this bridge, how we operate this bridge within sort of the framework of a practice. And as I just mentioned, where this essentially leads to, we really want to engage the entire community in working with patients with MOUD. Next slide. So beginning with how do we build the bridge? So community engagement, we really need to start. And again, this is kind of a system of care. So if you think about how we're treating MOUD, it doesn't rest just with a primary care provider or with the treatment organization. We really need to engage the whole community in this approach. And so it is helpful to have a community champion, usually at some kind of leadership level, who can work with not only their organization, but multiple organizations across the community to bring them together and get everyone involved in the solution. It also helps, there's obviously lots of different areas around treating MOUD, harm reduction, which we've mentioned, some of the acute treatments, some of the ongoing recovery, some of the social supports. And so it's helpful to do some sort of community needs assessment and understand where the gaps are. No community will be able to implement every single program out there, but it is helpful if you have components of each of those accessible in a community. And it's also helpful to have some one-on-one discussions with the primary care physicians. So you can begin to understand, since we're trying to engage them in this process, what is their perspective? What has worked in the past? What has not worked? What are their fears? In our case, there was a lot of fear that there would be a line of patients out the door, that this would disrupt their regular practice, and that they just were not well equipped from an education and other perspective to be able to treat patients. And so we actually worked on putting in place the systems of care that would start to address all of these concerns. And we didn't start with primary care. We actually started by meeting the patients where they were at in our emergency department, working with our treatment organizations, implementing Dr. Russell's program for the bridge, and then moving back to primary care. So you can see this includes a lot of community partnerships. It requires a shared vision. So we really need to have a vision of the system overall as we start, so we can continue to talk about where we're going. And then for the bridge itself, we need to have a clinical program champion like Dr. Russell, who is a champion working with the treatment organizations and also working with primary care. Next slide. So you have your current practice environment today where there may be limited access to MOUD. The idea of the bridge is to provide a bridge between where you are today and the vision for the future state where you have a more robust system of care. It's there just to fill a temporary need, and it's focused on providing MOUD outside of primary care. So it's really a bridge until you feel like primary care is ready to take on this responsibility. And that may happen slowly over time. You will have practices that begin to engage right away and other practices where it takes significantly longer. Next slide.
So thinking about the kind of things that you have to have in place to help get this off the ground when you're building the bridge, I do think having champions for the program is really important. Having a clinical program champion is really important, especially if you can find somebody that comes from a background in primary care. We felt like we needed to approach this really with a sensitivity to the immense pressures that primary care clinicians are under. Oftentimes, when asked to do something new, their first response is, well, I'm already managing a patient's depression and diabetes and high blood pressure and insomnia all in one visit. And now you want me to add something else? Like you want me to take over their opioid use disorder? And so the ability to listen thoughtfully and to approach this from a sense of shared understanding of the burdens is really key. Once at least in our experience, once the PCPs felt like they were understood and heard, then that's where the clinical program champion can begin to share their successful experiences with prescribing these medications. This person also needs to be skilled at relationship building, as Michelle mentioned, with the treatment organizations as well. One mistake that we made early on was with one of the substance use facilities that was about 2 hours away, and we had multiple phone calls and video meetings with them. And this is actually all before COVID, over the course of about 6 months. And they kept during the meetings saying they were very agreeable to partnering with us, but we never got any referrals. And finally, we drove down and we met with them in person, and immediately we started receiving referrals of their stable patients who we were able to take over. And when we asked them for feedback and kind of about the change in how many referrals we were getting, they told us that they really wanted to meet us in person, and that helped them feel comfortable trusting us. And then they were able to share with their patients, oh, we trust these people, we've met them, they're nice and trustworthy. So that was an interesting lesson for us at the beginning. The clinical program champion also needs to have some clinical skills and some administrative skills to run the telemedicine program. Primarily, this involves kind of scheduling clinician coverage to make sure that there is always somebody available, as well as being available to consult with the treatment organizations if there are questions about the referral process or the appropriateness of certain referrals. We want to make it clear that the scope of this bridge is specifically to prescribe this pharmacotherapy for opioid use disorder until there is capacity in the local community. And it is to act as a supplement, not a competition with the local primary care PCPs. And the clinical program champion is also available to help facilitate the transition of patients to telemedicine when they're stable, and then potentially back to higher levels of care if needed. Prior to COVID, I think there was much more skepticism about the appropriateness of using telemedicine for opioid use disorder. However, we've all been thrown into this environment where we often did not have a choice if we wanted to safely continue to prescribe these medications for our patients without putting them at risk of potentially getting COVID if we ask them to come into the office. So our experience, and the experience of many in this field, is that the relaxation of rules surrounding the use of telemedicine, especially for opioid use disorder and other substance use disorder treatments, has resulted in an expansion of access for patients with very few downsides to it. And in fact, the research shows us that outcomes, patient satisfaction, and adherence is as good, if not better, for telemedicine than for office-based medication prescribing. It's also an approach that has been successful in expanding access to these treatments in rural communities. Important considerations, as we mentioned before, it's mainly appropriate for use of buprenorphine or the brand name versions of this. Methadone is still highly regulated, and you can only use methadone in opioid treatment programs. And naltrexone orally potentially could be used in telemedicine, but it does not require a DEA waiver. And so naltrexone is often done routinely in primary care. And also, if you're doing the injection-based one, it requires nursing staff to administer, so may not be a good fit for telemedicine. There are also some patients for whom telemedicine may not be a great fit. This might include patients who have a pattern of missing a lot of visits, who may request medicine early or in between visits, who have been requiring frequent dosing changes, or who have really unstable mental health conditions. I do want to note that we have been using telemedicine for patients with active depression and anxiety, and they typically do quite fine with telemedicine. Okay, so as I have kind of alluded to, that one of the biggest factors in the success of a bridge program is really strong communication. So between the medication for opioid use disorder, or the PCP in the long term, and then the substance use disorder treatment program. The clinical program champion and the treatment organization develop the referral criteria. Often this includes their previous attendance, their appropriateness of their urine screens, the type and dosage of medication, and the stage of recovery that the patients are at. As I mentioned before, telemedicine may not be appropriate for all patients, depending on how stable or unstable they are. We do have an example of our intake packet on our website, which there are links to later on in the presentation. So we're quite happy, and we actually love for patients to use our intake packet, or organizations to use our intake packet. No need to reinvent the wheel on all of this. As you're working through this, one of the times when patients fall through the cracks in all medicine is during the transition periods. So making sure that you have a good and safe plan for how to transition between the substance use disorder treatment program and the bridge program is very important. Oftentimes this includes, we usually schedule a visit first before we transfer the prescription, just to make sure everything is kind of all set. And then the second visit is when we take over prescribing, and that helps us make sure that there's no gaps. And then again, communication with patients at all stages, comfort with the prescriber, so having them meet the telemedicine prescriber, and then with the technology, we're all getting more used to Zoom, although as I demonstrated earlier, there's always technology flubs, no matter how many times you've done certain things, and so practice can be helpful. We usually do ask the patients that they practice logging on beforehand. So thinking about how this process works, as I mentioned, we do have an intake packet. So patients will attend their treatment program, and when they're close to graduation, that's when they will be thinking about, okay, what's my aftercare program? Oftentimes, previously, treatment programs would be sort of keeping patients indefinitely, possibly longer than they needed to be in that level of care, because there wasn't the availability or the access to long-term maintenance prescription. So one thing that the bridge offers is this ability to, as we mentioned, kind of graduate patients from this higher level of care to a lower level of care. And this makes space in the treatment organization for patients who need the higher level of care. When patients are ready to graduate, they complete an intake packet. That's what we have available on our website that you can review. Usually the patient and the treatment counselor complete it together, and then it gets either faxed or emailed to our coordinator. The coordinator reviews it with me, and then we schedule the telehealth appointment if the patient is appropriate. The bridge provider completes the intake. Generally, we schedule these for longer than a typical visit, so we can do a full thorough history. And then you, at the time, the way that we have this set up is that the provider themselves either schedules or at least picks the time for the follow-up, so that there's not also, they don't have to play phone tag with our schedulers. After that, the patient can do either an office or it's not really a home base, but if they're at home, then we can send the order for the urine drug screen to the lab, whatever's closest to where they are. And then, assuming that all goes smoothly, that's when the patient officially transitions to the bridge program. Then, when the patient's doing really well and or when the local PCP has become waivered to prescribe Suboxone, that's when we can transition the patient from the bridge provider to the local PCP. And they certainly can see them at their practice, or now, as we know, telehealth is becoming much more common, so they may also use telemedicine. And they will have indefinite ongoing 20-minute follow-up visits for prescribing of the medications. Thinking about the logistics about telemedicine, there's sort of two options. One is office-based. That's what we were using before COVID, where there was actually a suite in the rural community, in the hospital of the rural community, where a patient would go to that suite. There would be a computer set up and a nurse or a medical assistant there who would work with the patient to help them log on, while myself or my partners would be in our office in the urban center. The advantages of that is that there is a nurse or a medical assistant to work with the patient. They can actually collect the lab at the time there. They can help the patient log on if there are any technology difficulties. With COVID, we very rapidly, along with everyone else in the world, transitioned to mainly home-based telemedicine, which we've all learned has huge benefits, including primarily incredibly convenient for patients. They do not have to take necessarily time off of work. A huge advantage, particularly for the women patients that we see, is they don't have to worry about childcare, which was classically a huge barrier for parents for getting treatment. You do have to think about privacy, so using a HIPAA compliant platform, and then arranging for a urinalysis. In our case, we were able to order this at a local lab, and we had to do some communication to kind of set this up and understand what the expectations would be. But once we originally set it up, it's been happening very smoothly. So ordering it at the lab instead of collecting it in person. And then also thinking about workflows, troubleshooting the telemedicine. And then one thing I will say about the scheduling, we do try to make sure that we get the next appointment scheduled, or at least pick a slot for the next appointment before we hang up with the patient. Because what we found was if the provider didn't do that, if the clinician didn't do that, and we left it to, okay, the secretary will call you, many times between, playing phone tag and patients not having great access to phones, we would not then get a follow-up visit without a lot of extra work. So just before you hang up or before you close the Zoom appointments, we do recommend that you just make a plan for the next appointment. It really helps to avoid gaps in care. Billing and payment, again, many of the rules were relaxed around using telemedicine, so it really has not been too much of an issue now around billing normally, particularly for video visits. Okay, so where do we hope this bridge leads to? Well, as we mentioned, we really would like the local primary care practices to take over the long-term maintenance. So engaging with PCPs has been a big part of what we do. So we want this bridge to be temporary. We really want patients to go to their PCPs for the long-term care. But it takes some work. And again, it is something that many PCPs did not learn in med school or residency. And so we're having to do some of this work at the same time. So some of the work we've been doing, one is overcoming these obstacles for prescribing these medications in primary care. I think the biggest thing is getting your foot in the door. So we have been doing this kind of similar presentation in many different locations, in many different groups. And a lot of it is just myth busting and sharing our experience, talking about how we've been doing this, talking about how we really have not had a lot of issues. It's very satisfying from a clinical perspective. The patients, it's one of the rare win-wins in medicine where it's great for patients and it's also great for clinicians. So really, I think the biggest thing is getting your foot in the door and talking to people about it. And then we also have been talking about how easy telemedicine is and how you can use telemedicine for this particular issue, because I think many PCPs would not have thought necessarily that you could use telemedicine for treating opioid use disorder. Another big part is the training. So a big push before for us was facilitating the X waiver certification. Now that that is not part of the rule, we do believe there is some training and education required. 8 hours was always kind of an abstract number that felt sort of picked out of thin air. So I'm really glad that that 8 hours is gone. I do think that because we don't do a great job of teaching this in med school or in residency, there is some training and education that's required. So that's another part that Michelle and I are working on right now is, okay, 8 hours was probably not the right amount. What is the right amount? And how can we do that in sort of bite-sized nuggets that are doable for very busy PCPs? And then
Dr. Russell,
oh yeah.
before you go on, yeah, I have a question. So what is the reaction of patients to using an entirely virtual visit for this kind of approach?
I mean, our experience is that patients love it. You know, I mean, I think it's just so convenient. I will say not universally. There are some patients who prefer an in-person visit, and now that we can offer that too, we certainly do. But for the most part, patients generally really love it. They like the convenience. As I mentioned, they really like they don't have to worry about job or childcare. And we've even had patients who have traveled and have been able to, usually we have to kind of reschedule their visits and figure out when their prescriptions due, and it can cause some kind of stress and anxiety for patients who are going on trips. And actually that's another great sort of undersold, I think, benefit of telemedicine is that patients can go on vacation and not have to have anxiety about their prescription running out. Like we've definitely done visits for patients who are in Maine or in, I think, South Carolina, you know, so that's another benefit to it, both the telemedicine and the ability to do electronic prescribing. And then the other aspect in terms of engaging with PCPs is really mentoring. And so finding people who are experienced with this, who are willing to mentor PCPs as they come on board. And this was definitely something that we heard loud and clear at the beginning is, you know, when you're asking a clinician to do something new, you need to prescribe or you need to provide support for them. It really is kind of not surprising that they don't want to do this without some backup. And so we offer support by phone or email. We do offer to review charts if they have questions, and we do have a process for urgent situations if they are if something comes up urgently. So somebody said in the chat 60-40 on preferring in person over virtual. Yeah, I know. And so who knows what's going to happen now in the next couple of months with the Delta variant, whether we'll go back to doing more. But yeah, certainly there are some who have a strong preference for in person, and it's nice that we can offer both. Okay. And then, so what do we think? How do we transition this care? So usually the way that it happens for us is we talk to the patient and say, do you know, actually, usually what happens is the patient brings it up for us because it's more convenient for them to get their care, have to go to one visit as opposed to multiple. And so oftentimes I'll either reach out to the PCP, one of our team members, or sometimes we tell the patient, you know, mention it to your PCP, see if they are interested in getting the waiver, if they want us to help. If they have questions, we're always happy to kind of reach out. And then we do also include a lot of resources for PCPs about, again, this is very new for many of them, and it can be really scary if a patient relapses, particularly if they're doing well. And so a big part of our guidance for PCPs is that relapse is expected. It's an expected part of the recovery journey. Relapse is part of recovery. And we also kind of help them through with different levels of relapse, which we do have later in the slides that we might not get to it because I do want to leave time for questions, but these slides will be available, and we're also always happy to talk things through outside of the webinar. And then one of the things that I think is most critical that often gets overlooked is the open line of communication with the substance use disorder treatment programs. So because this has been typically very siloed, right? Oftentimes substance use disorder programs kind of happen on their own. They're outside the rest of the medical center, or they're outside of the rest of the healthcare system. So, and sometimes when you call, there's like an extensive phone tree and you have to press 4 different things to get to a live person. And so one of the things that we've tried to set up within our community to get PCPs on board is easy access to these SUD centers, so that if a patient becomes less stable, they can be referred to a higher level of care without the PCP feeling like, oh my gosh, I can't get through, I can't refer. So I do think that's a really important part, that this goes both ways, right? So the substance use centers have good communication with the PCPs. When patients are stable, they can send them to them, but vice versa, when patients become unstable, there's an easy bi-directional way that we can get them to the higher level of care without it feeling stressful for the PCPs. Okay, and then thinking about closing the bridge program. So when do you do it? How do you do it? Well, a big part of this is the local access, right? So the goal here is, again, that this is a temporary program until the local PCPs feel comfortable, are up and running, and that there's enough access locally. This is always a goal from the beginning. So I think that's another important part of the bridge program, is that it's very clear from the beginning that this is a temporary program. And as we've said throughout, communication is a huge part of this. So regular conversations with the substance use programs as well as the PCPs to understand what's the access, how long are patients waiting, what are the needs in the community, and are we ready to shut this down? And then of course, as you're reviewing the progress, you're not just gonna say, okay, lights are out tomorrow. It's a phased program, so that you're kind of off loading is not, doesn't really sound like the right term to use for humans, but you're basically transitioning the patients to their PCPs, or you're making sure they all have a plan for long-term maintenance. And that's really the most important thing with all of this, right? Is that the patients have the place that they can get their treatment ongoing for their chronic disease. I'm going to skip through some of these slides, which are really more focused on specifically a primary care audience and really getting them up and running with this. We've gone over a lot of it, but I do think this is an important kind of summary where this is the way that I think about primary care, our role. One is opioid stewardship, right? So that's appropriate prescribing of opioids in the first place. 2 is improving access. So thinking about, can we prescribe these medications within a primary care setting? And then 3 is this hub and spoke model of care collaboration. And here's a little bit more about the hub and spoke, made famous from Vermont, but this is really kind of what we based our program on. And again, just kind of focusing on this bi-directional relationship between the hubs and the spokes. Okay. The hubs, and we kind of call ourselves the sub-hub. The telemedicine program is sort of a sub-hub, but we offer treatment intensity and staff expertise that some people require when they first seek substance use treatment. And the patients may move back and forth, as I mentioned, as their treatment needs and their acuity changes. And then the spokes are generally PCPs in the community who are waivered to prescribe buprenorphine. And patients generally transition to the spokes when stable. The bridge is sort of a sub-hub, or something that you can think of as an in-between part between the hub and the spoke. And this, I just want to highlight this slide, and then we'll kind of move on to sort of conclusions and questions. This is something that we often hear as a fear of PCP offices, that they are going to become treatment referral destinations, that they are going to be asked to provide a medication to an unstable patient, or that they will have to open their panels, even if they're closed, to new patients. And of course, the fact that you have to get a waiver, even still with the new rules, it does turn some people off, that they might be having to write a high-risk medication. And we also worry about the staff, right? Especially with COVID, many offices are understaffed, and they do not feel like they have the office staff or the resources. And we do like to really reinforce that you don't need a Suboxone nurse, you don't need a specific session. This can just be mixed in with routine primary care. So this is what we're asking primary care to do: treat their own patients who are stable and require long-term buprenorphine treatment. And when and if a patient becomes unstable, assist them in getting back to a more intensive outpatient program. And that's it. So I do think if you can think about it this way, think of it as a chronic disease and ask PCPs to provide this long-term maintenance for this chronic disease as they do for many others. That's really the message that we're trying to promote. I saw you looked at you.
Dr. Russell, we have a question I think is related to this last part. So from Celie Raglan, what happens when a person relapses and how many times are they able to relapse or inappropriately use the program, i.e. going to more than one provider for more uses? So can you address that a little bit here?
Yeah, absolutely. So we do actually have some information about relapse. Just this is kind of the way that we approach it. So again, I really do try to share the message that relapse is part of recovery. So it's actually not a surprise. It should be an expectation that along the way, there will be times where patients are stable and times where they're not stable. This is the way that we approach it. I do not think there's a perfect wrong or right way. And this is the hard thing about substance use treatment and addiction medicine in general, is that we don't have perfect algorithms. This is a complex disease, and really patient-centered care is the number one thing. So if I can sort of answer that with one sentence, it would be really, what is the best thing for that patient, and how can you provide the patient the best care that works for them? I will say in general, this is kind of our perspective. So if a patient lets us know and they tell us, as opposed to us kind of finding out from the urine drug screen, I think of that as kind of a lower level relapse as opposed to a higher level. From a harm reduction perspective, we do try to err on the side of continuing the medications as long as possible. Of course, if there are safety concerns, that's a different story. But for the most part, if patients are relapsing, if you can continue the medications, that's the patient's best, that gives the patients the best chance of success in getting back on track and also not overdosing and dying, right? So if a patient dies, we can't treat them anymore. So the best thing we can do is keep the patient alive and then do whatever we can to get them back into the right level of treatment. From our perspective, marijuana is a really low level concern. I think one of the things that does change the conversation with marijuana is that at least locally, we're seeing it mixed with fentanyl. And so having a sense of what's going on with the local supply of marijuana will help you counsel patients. So the way that we talk to patients about it is, at least in New York, right now, things are in flux, but primarily medical marijuana is what is legal right now. And so if we can get patients to buy the legal medical marijuana, it's certainly it's much more safe. It's much more expensive, which is the part that is a challenge. But for the most part, we don't do much, I would say, about marijuana use. This is our sort of response, and this is the way that we coach PCPs about this. Either non-opioid really or a rare occasional opioid relapse, we really try to increase the visit frequency. We do more urine drug screens. We try to increase the psychosocial support. And primarily, the number one thing I would say is to identify relapse triggers and try to avoid them or figure out what might have happened, what might have gone wrong to get them off track. Certainly, film or tablet counts are an option. I have not found that they're super successful because generally, it's hard to get patients in if they know their pill count or their film count is going to be off. And then you've just kind of got yourself in a bad cycle of like, well, I asked you to come in and you didn't. And then it's hard to mandate patients to come in for that if they're not due for a prescription. And then if it's a higher level or multiple relapses, we do have a relationship with our local substance use disorder program where we can refer them to a counselor. And so that's a great resource that we've kind of developed along the way. We also in our community have more and more peer recovery specialists, so trying to get them involved if possible. Consider urine drug screens between visits, and certainly referral to a higher level of care is always an option. And oftentimes is the right option for the patients. And then the hard part is when those things are not successful or when the patients don't do those things. And then I do think at that time, you might get to the point where you give the patients a time frame in which you expect them to come into compliance and then clarify what the consequences are. Again, depending on what your community access is to a higher level of care, that might change what the time frame is. In our community, we know patients can get in pretty quickly. So we generally give patients 3 or 4 weeks if we feel like they've gotten to that point where they definitely need a higher level of care. If the patients don't go into a higher level of care, I do feel like we're doing them a disservice if we continue to prescribe to them indefinitely because they're not at the right level of care, and that could potentially be harmful for patients. So, Michelle, do you want to recap and wrap up?
Sure. So I think that Holly's done a great job of explaining sort of how we build this bridge and how we operate it on a day-to-day basis in a primary care practice. And in terms of where the bridge leads to, I just want to re-emphasize again that ultimately we want to be able to close down this bridge program when the primary care practices are really engaged and they have the right care management infrastructure in place to help them be successful. The ideal here is really that the practices are feeling like they're at a point where they can be successful, and that may not all happen at the same time. So this is sort of a transition you might need to do over time with different practices as they're ready. Next slide. I want to open it up to any other questions. While we've got a couple comments coming in and also questions. So hang on one second here. Okay, from Michael Schwartz, a comment on the previous questions. Substance use disorder is a chronic illness, much like diabetes, CVD, and cancer. Withholding treatment due to behavioral issues is not appropriate. I think we totally agree.
Yes, I hope that was clear from my answer. We really, as I mentioned, I think the medications we know save lives. And so if you can keep the patients on the medications, you know, that's really the number one thing, and then sort through some of the other stuff.
Okay, sorry, I'm looking at 2 things at once here. Okay. So how do we support patients without broadband access? So I'll kind of jump into that first, and you can feel free to add to this, Dr. Russell, but we have telemedicine suites embedded in our hospitals in all of the rural communities that we serve. And we've actually just started, so patients can go into those telemedicine suites and they can access telemedicine from there. But we also have just started using Wi-Fi hotspots on several of our buildings as well. And so in those cases, a patient can drive up and they're not using their minutes. They can use their own device, but they will be accessing our Wi-Fi and then access telemedicine from their car in a designated parking spot. So we've tried a couple of different things that really try to address that limitation of access in these other communities.
And I would say phone calls too, you know, I mean, you can't bill as much for, at least I'm not sure if that's a national law in New York, you can't bill as much for a phone call, but certainly I would never hesitate to switch to a phone call if that was gonna increase the access for a patient.
And Holly, what was the biggest unexpected challenge you had in this program?
That's a hard question. I mean, I think many of the challenges we expected. I think the biggest one I would say is the relationship building in person, and how important that was. You know, I think that was definitely surprising to me because I don't know. I guess I was like, well, of course we're trustworthy, but I think in a community where we're going, they don't know us. And I think, sometimes in the more rural communities, they can be a little more protective. And so we're sort of like the outsiders from the big city. And so I think that was probably the most surprising thing for me, is how much it was important to really see them in person, but also just kind of like maybe have a little more humility about kind of what they might want from us or need from us, I think.
Great. I don't have any other questions, and we're perfectly at the top of the hour here. So I think, Kimberly, did you have some comments you wanted to make at the end here?
I did. All right, hi everyone. I'm back from earlier. Wanted to just tell you a little bit about Project Freedom and what we do. Project Freedom hopes to decrease the adverse impact of opioids on Alabama residents through education and access to opioid reversal medication called Narcan. And we service 16 different counties. And if you hear yours, just let me know. Blount, Coleman, Etowah, Fayette, Franklin, Jackson, Lawrence, Marion, Marshall, Morgan, St. Clair, Shelby, Walker, Winston, Jefferson, and Tuscaloosa County. And so what we do community trainings where we train the community on topics such as the dangers of high toxicity opiates, proper use of prescribed opiates and disposal, Good Samaritan law, mental health first aid. We do our training via town hall meetings, any health fairs, community-based education seminars, and we do health provider training as well. And we do, opioid overdose dangers, treatment and recovery, military veterans, cultural competency, and treatment utilization. We also train first responders as well. And what we found in training the first responders is that new information is available that they didn't know about. So I'm always so happy to provide that information to them, because Alabama is one of the ones that rank top in dispensing opiate medications. And so we make it a practice to let them know the latest stats with fentanyl and being exposed to it, and how do you protect yourself from being exposed to it. So we offer some different services at Project Freedom, and I can email you guys if you heard anything that you want us to help and to train on, because I believe knowledge is power. So we believe in sharing it with everybody. It takes a whole village to work together to make these numbers go down. But I'll put it in the chat, my information in the chat box. If anybody want to get in contact with me, I am the Project Freedom Outreach and Training Coordinator, and my supervisor is Wendy Hogue. She's the project director. And I want to just thank you guys for participating in the webinar today. An evaluation will be sent to your email on Monday, and we hope to see you in the upcoming webinar. Or I hope to hear from you so that we can provide some training. I don't know if I said about mental health first aid as well. We do that as well. So thank you guys for participating.